I am Director Youngjae from the Korean Dental Hospital. Last session, I discussed the differences in occlusion between implants and natural teeth. I mentioned how the presence or absence of the periodontal ligament affects the elasticity and movement of the teeth. Today's topic is centric occlusion contact. In fact, there are two approaches to this. Whether we consider the concept of centric position based on the teeth or the jaw, there are these two directions. Thus, there exists a separate centric position for the mandible and for the teeth. I had previously developed an occlusometer, and upon my recent visit to China, I discovered what appears to be an exact copy of my design. This occlusometer has a pin, and within that pin, there's another spring pin. The seller didn't even know how it should be used. It seems they were conducting seminars to sell these, and when you perform a Gothic arch tracing, it reveals the central position of the mandible. If you replace the pin used for that arch tracing with a spring pin, it creates a hole in the plate at that central point. When that point is engaged, the spring pin is inserted. Then, there will be an area where the teeth make contact first. This ultimately plays a role in identifying the discrepancy between the centric position of the mandible and the centric position of the teeth. Previously, we approached centric occlusion with concepts of CR or CO. Of course, at that time, since gnathology started with the concept that the TMJ is the prime factor and dental occlusion should conform to the TMJ, there was no other option. And this concept has been maintained for a long period. However, from our perspective, we cannot pinpoint the position of the TMJ. So it seems that even gnathology initially started with CO. From the physiological position, it then moved to CR and later to CP, but essentially, it has returned to the old concept of CO. The centric position of the TMJ, especially that of the mandible, has constantly changed and is judged not to have been maintained. So, to summarize the current situation briefly, it seems that there are fewer proponents for issues related to the TMJ side. Many professionals are contemplating how to align the centric occlusion of the teeth. If you confuse that part with what was previously explained as TMJ, understanding occlusal adjustment becomes difficult, leading to a perception that occlusal therapy is complex. Therefore, today, rather than focusing on TMJ, I would like to talk about tooth contact, specifically how to form and adjust the maximum intercuspation position. So, when discussing the occlusal contact in centric position, the holding cusp becomes a crucial concept. Thus, when we bring up holding cusps, it often seems surprising. That's because it's not a term you typically hear. However, until the 1970s and the 1980s, instead of using the term functional cusp, we referred to it as the holding cusp. So I would like to explain what this holding cusp is. The holding cusp, as you can see, involves the maxillary lingual cusp being held in place on the mandibular occlusal plane. That is, it's trapped. It's a situation where the internal inclines and external inclines are interlocking on the occlusal plane. And similarly, the mandibular buccal is also trapped by the maxillary occlusal plane. This is referred to as holding. And in cases like the maxillary buccal, one side is not engaged and remains open, and the same applies to the mandibular lingual. Since the lingual side does not contact the occlusal surface and remains open, the maxillary buccal cusp and the mandibular lingual cusp are called non-holding, while the maxillary lingual cusp and the mandibular buccal cusp are referred to as holding cusps. Why is this holding cusp important? Let's explore that now. The opposing teeth that are interlocking are actually holding the maxillary and mandibular teeth in an interlocking structure. So it's the teeth themselves that are being held. Hence, in order to keep these teeth from moving and to maintain their position, this interlocking of the holding cusps forms what can arguably be considered the central occlusal position in maximum intercuspation, which is a crucial point for centric occlusion and tooth contact. Therefore, this concept is most important in centric occlusion. It becomes a fundamental principle, if you will. So, as teeth are used, they will experience wear. Of course, when you observe the occlusion, food particles get stuck between the upper and lower teeth. So during actual mastication, the teeth do not touch each other. However, at night, whether due to grinding, clenching, or even during swallowing, the teeth continue to make contact. This is when swallowing occurs. If the teeth contact each other in this process, they wear down, and this pattern of wear results in both the inner and outer surfaces of the holding cusp making contact, while only the inner surface touches in the non-holding cusp. It's the same scenario, both the inner and outer surfaces of the holding cusp come into contact. Whereas, for the non-holding cusp, only the inner surface touches, resulting in many instances where a tooth's N-shaped form changes to an S-shape. So why is this important? Since both the inner and outer surfaces of the holding cusp are in contact, as time progresses, you'll see that when the mandibular lingual cusps protrude sharply and the maxillary buccal cusps also protrude sharply, the holding cusp collapses vertically like this. Upon examination, there is a reduction in vertical dimension and development of point contacts. Therefore, as I will mention later, terms like tripodism, central occlusal contacts being in tripodism, or contacting through surfaces, or what is called surface contact, are practically meaningless. The inability to distinguish arises because in cases where there is no wear, tripodism predominates, and when wear occurs, tripodism cannot exist. Therefore, when we consider the concept of wear, the shapes of the teeth and prosthetic devices become clearer to us. So, there was a query from a colleague today regarding a case where the patient has a denture on the upper jaw and natural teeth on the lower. He asked how to manage this situation. As you know, we need to achieve fully balanced occlusion. However, when wear occurs, it becomes impossible to maintain the holding cusp. So what should we do about the opposing teeth? If we don't align the worn surfaces according to this wear, it becomes difficult to achieve both centric and eccentric occlusion. Moreover, if the occlusal surfaces are not uniform, they become uneven. Some opposing teeth might be extruded, and some might have had poor alignment from the beginning. Ultimately, we need to achieve a fully balanced occlusion within the occlusal plane itself. Last session, I mentioned that the same applies whether the opposing teeth were a denture, an overdenture, or even when dealing with a full mouth implant. If the opposing teeth exist in such a worn form, this worn form must be accurately reflected. If we use a denture for the opposing teeth and leave the natural teeth of the lower jaw as they are, the only option is to adjust the opposing teeth by performing selective grinding on the denture teeth. Therefore, this concept is crucial. However, didn't I mention earlier that these teeth interlock, causing the teeth to be held in place? If you consider the roots of these teeth, they are embedded in the bone. Consequently, the holding of these teeth ultimately leads to a situation where they hold the mandible. Looking here, we may refer to these interactions as contacts A, B, and C, seeing them either collectively or individually, yet the anterior teeth do not participate in this holding structure. Therefore, they cannot hold the mandible. If they touch, they merely slip off. Only the molars that have a holding cusp do so during maximum intercuspation. Thus, only when centric occlusion contact occurs do the teeth manage to hold the maxillary and mandibular teeth in an interlocking structure. That ultimately involves a process of mandibular holding. So as we discuss various topics, in the case of the mandibular incisors, it goes like this. The holding has been maintained, and the non-holding has evolved into the cingulum, whereas for the maxillary incisors, it's the opposite. The holding has evolved, and the non-holding remains. Thus, we can conclude that the cingulum itself represents the evolved form of the holding cusp in the maxilla and the evolved form of the non-holding cusp in the mandible. Of course, such interpretations are not commonplace. This is a concept I have organized. It is not one found in other papers or academic journals. So in a way, there might be no evidence-based approach, but from a repair philosophical, geometric, and mathematical modeling perspective, the consensus is that such a conclusion emerges. Without understanding this, there is no way to convince him. Then why is the maximum intercuspation so important? As you can see, the TMJ is actually held by ligaments, with a disc in between, divided above and below by the disc, containing a synovial sac and synovial fluid. This means that it is indeed difficult to pinpoint its exact location. What I mean is, because there are buffers in the joint, including the knee joint, all joints have a buffer space when pressed. So regarding TMJ determining the position of the mandible, stabilizing in a specific position means, in fact, it is an impossible task. So, in considering this, you can see how the masticatory muscles are attached like this. The masseter, temporalis, internal pterygoid and external pterygoid muscles are attached. These are ultimately lifting the mandible against gravity. We are currently raising it. So think of it as being lifted, and we call these the anti-gravity muscles. Thus, these muscles oppose gravity and hold the jaw in place, ultimately maintaining the position of the mandible. The movement of the jaw is described as a swing-like motion. Therefore, in the literature, the term suspended mandible is often used. So it's hanging. Like when we do chin-ups, we describe the mandibular structure as being suspended in a similar manner. The induction to maximum intercuspation primarily involves the function of the muscles up to a certain proximity. When the holding cusp of a tooth or its inclines meet, they ultimately reach their final position. So, when the structure where the upper and lower holding cusps interlock is completed, the mandible becomes stabilized. Therefore, it is described as both the starting point and the end point of mandibular movement. Of course, the jaw moves on its own accord. It moves freely within the spatial constraints. However, when one attempts to swallow, the mandible must return to its proper position. After it returns, the jaw is drawn backwards, engaging retrusive guidance, allowing swallowing to occur. Therefore, we perform prosthetic treatments, install implants, and fit dentures to create this structure. If this dental occlusion is not maintained, the position of the jaw continues to distort. You'll see that in patients with malocclusion, their jaws are also misaligned. TMJ disorders can lead to asymmetry on both sides, and there are many patients whose maxilla, facial bones, orbital bones, and even the skull have become distorted. This implies that the motion of the jaw is connected with the head, and the maxillary and facial bones exchange forces. When occlusion occurs, this occlusal force eventually disperses around the nose, eyes, and skull. Therefore, when asymmetrical occlusal forces occur, it starts with asymmetry of the jaw bones, followed by the maxilla and mandible, facial asymmetry, and then asymmetry of the skull, which eventually leads to a cascading effect on the entire body. This visual confirmation highlights the importance of occlusion. The root of all these issues stems from the asymmetric formation of the maximum intercuspation. This affects growth and development, and as problems escalate, they can manifest as systemic issues. Thus, the concept of mandibular holding is very crucial. The issue of whether this is symmetrical or asymmetrical is the most challenging aspect, which is why orthodontic treatments or full mouth rehabilitation are considered valuable treatments. Due to misalignment in the skull or facial bones and the mandible, it's impossible to achieve symmetry in the teeth if they are already misaligned. Recent developments do allow us to apply traction to the skull or pull on the facial bones or the maxilla, yet there are still limitations. Many individuals have an inherently misaligned skull. The base of the skull can also be twisted. It is not easy. The inherent limitations in treatment make it especially challenging. Therefore, early treatment, such as intervention during the period of primary tooth exchange, holds greater value. This is because the TMJ has not fully developed. When that happens inevitably, I believe it is most valuable to be able to align both the TMJ and the symmetry of the jaw, as well as achieving TMJ symmetry. We discussed the wear of the holding cusp. Wear increases with age. When wear occurs, the height of the cusps decreases and the inclination of the condyle also decreases. Of course, there are exceptions. In cases like class 2, if there is no wear on the incisors, there tends to be more wear on the molars. In some cases, the cusps of molars are worn down more pointedly. However, let us first examine a typical case. As wear progresses, the chewing surface area increases. So it is said that functionality and efficiency increase. The issue arises when the masticatory surface area, the area of tooth contact, increases. The periodontal ligament of the root and the periodontal tissues support the tooth, so at any moment when the occlusal force, the load of occlusion, exceeds the support of occlusion, ultimately, the periodontal tissue progresses towards destruction. This is actually a bit challenging. So, when we speak of the duality of duality, what we mean is, as these functions and efficiency increase, ironically, so does periodontal destruction. When we devise a treatment plan, what we initially considered, patient satisfaction post-treatment. I wonder if the sense of disconnection stems from this issue. It's the duality of duality. Reducing tooth contact can extend the lifespan of implants or natural teeth, but this compromises their function and efficiency. Additionally, expanding the surface area can increase functionality and efficiency, but it also raises the possibility of periodontal destruction. So, this results in a situation where one is neither able to proceed in one direction nor the other. Some patients have reported that they have never been able to chew on the side with the prosthesis and have completely been unable to eat food. That would be problematic. That's why I put it to you this way. The fingers move independently, but the jaw is one unit. Even if you chew on the right side, the left side is also engaged in the chewing process. Conversely, when you chew on the left, the right side is engaged as well. It seems like a bit of a misnomer because the jaw moves as a single unit. However, it might be expressed as, I am in the same situation as well. Soft or less hard foods should be chewed on both sides. However, if you feel that hard foods are chewed better on either the right or left side, you will tend to chew only on that side. Then, from the patient's perspective, he comes to believe that he is chewing on the right side. However, that is not actually the case. The patient is likely aware of this as well. When it comes to that point, there isn't much left to say. So I will explain. In the world, there are right-handed and left-handed individuals. Similarly, mastication has a direction, so there are individuals who chew on the left side and those who chew on the right side. Some patients may not understand even when explained this way and express their dissatisfaction. It is not easy to explain. However, a greater issue arises when this results in wear. The normal Wilson curve looks like this. The buccal is positioned slightly higher than the lingual. There is a form of Wilson curve present. As wear progresses, the holding becomes worn. In non-holding, the inner surfaces wear down, but in holding, the wear is more formulaic, ultimately changing to a flat Wilson curve. If this continues, the Wilson curve will change to a reverse Wilson like this. Such cases are very common. The content from here on becomes somewhat challenging. The vertical dimension has decreased, hasn't it? So in the end, what happens is the jaw experiences overclosure. Then the anterior teeth make contact. This results in overclosure. So there is overclosure, and the incisors are in contact. And retrusive guidance refers to the interlocking of the holding cusps as they move backward. The retrusive guidance has been eliminated. Eventually, this will result in the jaw moving backward. Therefore, many patients develop TMD and come to the hospital. In so many cases, we observe the loss of vertical dimension and the mandible retreating posteriorly. We often perform treatments that involve orthodontics or follow-up orthodontics with crown placement. However, surprisingly, there are quite a few who agree to do it again. This is because the extent of one's pain generates a desire for treatment. More patients agree with this than you might expect. So, as I mentioned earlier, the esteemed colleague wishes to apply a full denture to the maxilla, while there are still natural teeth remaining in the mandible. Since you asked if there's a way to properly handle this without placing a crown, he responded that the artificial teeth in the upper denture must be accurately aligned with the wear surface of the lower jaw through selective grinding. This is because when the lower teeth are worn down, it is logically impossible to align them with the occlusal surfaces of normally shaped artificial teeth placed above. The upper and lower are complementary symmetries, together like key and keyway. The structures interlock with each other, and this is referred to as the interlocking of the holding cusp. When the opposing teeth are worn down like this, rendering the occlusal surfaces flat, it's impossible for the holding structure to be properly formed. In this condition, it's hard to imagine aligning the teeth in their normal configuration. So, if you diligently sculpt the artificial tooth to align and match the wear facets with the opposing teeth, likely the centric occlusion will be accurate. If the overbite in the anterior region is moderately reduced, ultimately, the anterior guidance will be adjusted to the molar guide. This approach may be feasible, but it is not the standard method. Therefore, I believe that crowning the lower teeth is also a good method. The term holding cusp interlocking structure is referred to differently in various texts. So, when viewed from the side, that is, when looking at the sagittal planes, when we bite down, the incisors typically make contact first, and as the teeth meet, the jaw slides into place, allowing the molars to then make contact. The same applies when asked retrospectively. If it slides backward, the distal aspect of the maxillary molar will contact the mesial aspect of the mandibular molar, after which the mesial aspect of the maxillary molar will make contact, correct? The area that is first contacted is referred to as the stopper, and the sliding contact that achieves balance is known as the balancing tooth contact. This type of interlocking structure, that is the holding cusp interlocking structure, when completed, is referred to as an equalizer in tooth contact. Therefore, it can be considered that counterbalancing is involved. When one side of the teeth makes contact first and then slides into a balancing tooth contact, this achieves equilibrium and stops the mandibular movement. Thus, we refer to the first point of contact as the stopper and the point that contacts subsequently due to slippage as the equalizer. When viewed cross-sectionally, it is an ABC contact. When biting to the right like this, a stopper forms near point A, allowing it to smoothly slide downward. Then we can consider the B contact as an equalizer. Teeth have a three-dimensional structure, therefore they cannot be simply explained in 2 dimensions. However, when thinking three-dimensionally, whichever side is asked about, the part that makes contact first is referred to as the stopper. The dental contact that stops the sliding of the jaw is called an equalizer. If you consider realistically why such a theory is necessary, I believe that for everyone, the site where the holding cusp forms an interlocking structure becomes the final position of mandibular movement. He simply wasn't aware of it, as no one had explained it to him. However, when examining research papers and textbooks that discuss this matter, in fact, you can tell that the same content is being discussed. We must ensure that the interlocking of the holding cusp becomes effective for mandibular holding. The upper and lower holding cusp interlocking structure is formed. Interlocking of tooth holding must transition into mandibular holding. Mandibular holding, which is interpreted as both the final destination and starting point of mandibular movement, is what we refer to as maximum intercuspation. I believe this is ultimately referred to as central occlusal contact. The reason I am explaining this in such detail is because everyone tends to get confused about it. Just remember the concept of holding cusp interlocking. To explain this, we use numerous diagrams and terms. Stoppers and equalizers, or whatever the status of the TMJ, are described in numerous books and papers. In fact, observing cases where understanding becomes more difficult has led me to explain fundamental issues in greater detail. So in such cases, this situation arises when the mandible has been stabilized with the stopper and equalizer in place, but a balancing premature contact has occurred. There are areas that make contact first in this manner. Then the liver action is engaged. Ultimately, this results in instability of the mandible. This is too complex, so I will explain it in the next lecture. There is a separate section for lecturing on liver action. At that time, I would like to explain further. Ultimately, for the jaw to be maintained, contact must occur at about 4 points. The molars and premolars should thus contact in 4 places in a square form. It must contact like this, and if even one does not make contact and there is any movement, a class 1 lever is engaged. Therefore, we often observe the process where lever action occurs. By conducting a geometric analysis, we determine whether the maximum intercuspal position aligns with the centric relation. So the term all square comes from the incisors will ultimately not make contact in the centric occlusion. The occlusion is limited to the molars, where contact occurs within a rectangular area, forming a supportive surface. Thus, the structure where the holding cusps are interlocked is arranged like this. Similarly, it forms a rectangular structure with the TMJ. When we were young, we used to move around with wardrobes, didn't we? If you try carrying heavy furniture like a TV stand now, all legs are 4. That's stable. A chair has 4 legs, and problems arise when those 4 legs are not balanced. If this surface is not completely level, the balance of the 4 legs is not correct. And the same goes for the legs. Balance is achieved when all 4 legs are of equal length. So after moving, when our mother would fold a piece of paper multiple times to make it firm, I remember inserting it under the unbalanced leg like this to level it out. When we were in school, we learned a great deal about tripodism. Therefore, I believe tripodism is stable. Absolutely not. Tripodism allows for balance when the base is unstable. It is difficult to describe this as having achieved stability, because balance is somewhat unstable like this. Thus, we cannot describe it as stability. So what does a stable structure mostly look like? In the case of a house, it is a rectangle composed of 4 pillars, and almost all buildings adopt a rectangular shape as their base because it ensures stability. And the interior area is spacious. Triangles have a narrow internal area. To my knowledge, among these polygons, the triangle has the smallest internal area. So, a triangle merely maintains balance. It is not actually a stable structure. So, When I was young, I liked the design, so I bought a chair with 3 legs. When I did that, it kept tipping over as I pushed, so it was quite troublesome. So why do you think both the chair and the table have 4 legs? The operating room is rectangular, and you might see why the rectangular structure is used. So, I understood why the rectangular structure is a stable structure. All square means... This is a term used in golf. In a golf tournament, 2 players take their shots. Let's move on to the up and down movement. This is how you count the strokes. When it becomes equal in score, it is called all square. That statement ultimately achieved a balance. When we describe something as stable and balanced, we use the term all square. I also embrace this concept, where I consider it all square when a certain stability in the jaw is achieved. Whenever possible, align with any geometric structures that are rectangular. So this brings us to the issue of the all square problem. Ultimately, achieving all square is necessary to maintain a stable jaw position. This all square formation is the interlocking structure of the holding cusp. And in such cases, when the teeth make contact, it is referred to as the centric relation maximum intercuspation position. Next, we refer to this as the central occlusion of the teeth. So I have explained this in detail, but if you do not understand this structure, memorization is the only option. What is this here? You must memorize which surfaces of the lingual cusp, what surfaces, and so on. However, in the case of class 3, it is the opposite. This results in a crossbite. Then, things memorized in absolute positions become entirely obsolete and must be relearned. So, you end up memorizing it continuously until you eventually give up. In my case, actually, in nathology, concepts such as myop, eliop, theop have emerged. It seems that various things were memorized haphazardly. Which cusp, which surface, which side, that kind of surface, that was how I memorized it. I read it over and over at least 10 times, and I think I memorized it. I have always had a strong interest in occlusal adjustment. Again forgetting, again memorizing, and repeating this cycle over 10 times, it seems. I don't remember anything at all, so that would not be advisable. Using the holding cusp as a reference, the interlocking structure forms an all-square tooth contact. It's referred to as centric tooth contact, or maximum intercuspation. This becomes the mandibular holding, stabilizing the mandible. Perhaps we can consider ways to protect the TMJ area. When the jaw moves erratically in all directions, TMJ issues inevitably arise. If wear leads to maximum intercuspation causing issues in the TMJ, what should be done? It's quite simple. After removing all the teeth, a new position for the mandible was determined. Then, of course, under favorable conditions such as physiologic rest, after inducing the mandible under favorable conditions, the next step is to match it with prosthetic treatment, orthodontics in such areas. When we establish a new maximum intercuspation, it becomes all square and the TMJ is balanced. The concepts of maximum intercuspation, TMJ, and mandible holding in relation to the teeth. When balance is achieved, that ultimately amounts to TMJ treatment. Next, we address occlusal treatment, which involves orthodontics. That inevitably leads us to think of it as full mouth rehabilitation. So, after recording mandibular movements with the Gothic arch method, based on that record, we also control the vertical dimension. Next, after determining the 3-dimensional position of the mandible, if you cover the entire position with a crown, once all dental restorations are completed or implants are fully placed, then we proceed to prosthodontics. Full mouth rehabilitation is what it is, and if a full denture is placed in that position, it becomes a full denture treatment. By adjusting to that position, you achieve orthodontic treatment. Orthodontics itself is a form of full mouth rehabilitation. So, the tooth moves. This ultimately means that the position of the mandible has changed. So I was quite shocked when I attended a seminar by a particular orthodontist, and it has been over 20 years since then, so that might be possible, but he maintains this position of the mandible as is, and he stated that one can orthodontically move teeth wherever they desire. However, there is something known as extraction orthodontics. When you extract a tooth, consider this. The position of the jaw changes. During the process of tooth movement, the position of the jaw continually changes. How could such a misunderstanding occur? I found it quite perplexing at the time. However, Since my skills were lacking, I was unable to raise any objections, and at that time, I just thought that must be what he believes. Even now, I cannot understand why I thought that way. Ultimately, the jaw continues to move, and if the new maximum intercuspation is not unfavorable to the TMJ, if the mandible is not in an unfavorable position, the patient has no complaints, and if the conditions are not ideal, it leads to TMD, bringing patients to seek treatment. Many patients continue to seek treatment for orthodontic extractions as their conditions become more serious. Every time I find myself at a loss for words. We are transitioning to non-extraction orthodontic treatments and employing methods such as placing implants. So that is the situation with orthodontics itself. One thing I failed to understand was, before, those of you who practice full mouth occlusion have come. We've made extensive use of removable appliances. So it is an orthopedic appliance. Ultimately, that leads to taking measures such as expansion will change the position of the jaw entirely. This will not be correct at all. Then, almost all will tend towards the side where the jaw is more comfortable. So I believe it was probably treated, as I recall. He couldn't align the occlusion again. So you end up constantly arguing with patients? In circumstances where many unfavorable situations occur, I wondered why he was doing that. The next thing that was even more incomprehensible is that the Roth technique has been widely introduced in Korea. At Roth, what they do is, first the CR is used to position the jaw, and then the teeth are aligned to it. Ultimately, we perform a lot of surgeries. The direction is shifting towards performing orthognathic surgery, using an occlusal splint to change the jaw position to centric relation. That is to say, we will arrange the teeth there. That ultimately is gnathology. This is because, when guiding the jaw position with CR, there are techniques referred to as the one-hand technique and the two-hand technique. Relax your entire body and lie down, guiding the jaw with your hands, or sit and guide it to induce CR, after which all the teeth were trimmed to fit accordingly. However, that all failed, leading to the conclusion that gnathology does not work with full mouth either. Despite leaning towards not proceeding with full mouth rehabilitation, a conclusion was eventually reached. It's also humorous from our perspective. This is because CR refers to the rearmost position of the TMJ, where it is forced into alignment. It doesn't quite make sense. Therefore, in reality, when the patient's case is neither physiologically nor functionally concluded, some theories eventually disappear. So in fact, gnathology and its associated academic societies have all but disappeared, and there's a lack of belief in it now. It is outlined in the book. In universities, there's nothing left to teach, so we educate on gnathology. All the conferences have been cancelled, everything has been cancelled. Those who advocate for gnathology are like ghosts. Because he prioritizes the authority of gnathology over academic study, we only discuss things that are intangible. If we speak a bit more pointedly, I also do not understand the theory of Slavicek from Austria. Slavicek argues that there is a unique angle to each tooth. This is referred to as simultaneous occlusion because it is necessary to align the angles to achieve proper occlusion. How do you align the unique angle present in each tooth? I believe that physiological and functional occlusion can exist in various forms and from multiple perspectives. However, I am not sure why Slavicek made that judgment. Of course, I might have thought so, because I am not familiar with Slavicek's occlusal sequence. In any case, everything I have heard or seen in the research papers has turned out that way. So it is somewhat regrettable. In conclusion, regardless of the situation, you must always achieve all square. This is playing a crucial role. Therefore, in practice, there is a lot of discussion about tripodism. What happens when tripodism occurs? Based on the line connecting this posterior point, ultimately, both the TMJ and the entire occlusion will break down. The all square of occlusion itself is also disrupted. So, according to this criterion, the balance tilts back and forth. So, in conclusion, there is no support for the tooth. In the end, the vertical dimension is completely lost, and of course the opposing teeth are also extruded. The TMJ is wearing down. This is because the dental support is lost. So when we explain this, there's a lot of discussion about whether to place implants in the second molars or not. Many say that treatment up to the first molar is sufficient. However, is this correct? Consider the mandibular incisors. Below, there is no second molar, but it is said that it's sufficient to restore up to only the first molar. It's quite unconvincing, the story. So, it's not that he can't do it. Of course, it seems that you do that because you are concerned about causing distress. It may be done from a higher level perspective, but I'm not sure. It's not that it cannot be done. Rather, there is no need to do it. That's how you should express it. However, if you think about it, if even one tooth is missing, the opposing tooth becomes useless. So there are two missing, you see. There are two missing. So, it is quite regrettable why such a concept does not work this way. Especially there is an absence of the second molar. Then the TMJ will be damaged. I have seen many patients like this. There's no support. In the TMJ, the tooth closest is the second molar. Let's assume that one second molar is missing. Of course, we can't be sure what happens when both are missing, but it's also ridiculous to say that there's no need to restore when just one is missing. Recently, looking at how implants have been performed, it seems that there are quite a few cases where implants are placed only up to the first molar. Thus, it is referred to as a shortened dental arch. Therefore, if the arch structure is long, it bears more load, so the suggestion is to make it shorter. The second molar is implanted with a bias towards the mesial side. Therefore, I see a lot of such cases. Typically, the first molar is also involved. In cases where the first and second molars are extracted to clear the posterior region, this inevitably leads to problems with the TMJ, so the surface area of the all-square decreases. All-square patients are healthy. The tongue space is ample, and there is plenty of room to breathe, which is beneficial. So I'm not sure why such claims are made, but if one claims that the second molar is unnecessary, that it does not need restoration, then we should have extracted the second molars earlier. I don't know why we are still trying to preserve them. Claiming that something we are born with is unnecessary from the outset is illogical. They say 20 to 80, meaning it's sufficient to have just 20 teeth by the age of 80. The concept of necessity and sufficiency exists. It may satisfy the need for mastication to some extent. It's just that they can't express that it's enough. So it seems like a slightly different issue, but in any case, the maximum intercuspation position centers around centric relation, which means that the contacts of teeth in centric relation should be all square. That must be mandibular holding, only then TMD or deformations of the jaw do not occur. It seems this is the correct solution. Rather than calling it the correct answer, it's an obvious issue. It's rather amusing to talk about a correct answer. In fact, it's quite obvious. Of course, this is something that must be accepted, yet there are those who continue to seek technical shortcuts. Some individuals might phrase their statements to showcase their knowledge, but in my view, that is not the case. You must not do it that way. Instead, a more significant issue arises when such incorrect knowledge is passed on to or instilled in younger dentists who are still learning. Then the problem becomes more serious. Later on, the young dentists naturally consult with someone and agree on that point. Additionally, patients continue to experience pain and discomfort. Then you will come to resent the director. Ultimately, if this remains unresolved, I anticipate that our work will become considerably more challenging. So I drew this. It is difficult to express in words, because as we discuss whether this is the mesial or distal aspect of the lingual cusp, in the end, it all became so jumbled up that I couldn't understand anything. So, to put it simply, the holding cusp works like this. They come together like this for holding. This part moves in this direction, and conversely, the lower part moves upwards. It's a structure where the holding and interlocking occur together. Express it in this way, and one only needs to identify that in the oral examination. So let's simplify the conclusion, and once the image enters your mind, you cannot forget it. You must never memorize it just as text. Explaining a three-dimensional structure in words immediately loses its value. The most challenging aspect is when we extensively analyze the sagittal plane, transverse plane, and coronal plane. Doing so will make it more complicated to understand. When we learn orthodontics, we use cephalometric analysis. It appears that the success rate of diagnosis falls short of 70%. Diagnosing it doesn't hold much significance. Extraction and non-extraction merely distinguish between procedures. They hold no other value. In cases like Class 3, surgery, or the use of orthopedic appliances capable of fostering growth and development are the only options. You will use a facial mask or rampa. Class 2 requires mandibular advancement. However, to my knowledge, there is no device that inhibits maxillary growth. Even though there are methods to extract the mandible to induce growth, inhibiting the growth of the mandible is challenging. Facial masks, or rampa, serve to pull the maxilla forward, promoting growth and development. The mandible does not have methods to inhibit its growth. So it's somewhat ironic, but it's understandable to induce growth during the active growth phase, but overgrowth requires suppression of growth, but there is no method to do so. Previously referred to as a chin cup, we have frequently used devices that push the jaw, such as headgear. From what I hear, it seems there are still some in Japan who use it. However, the conclusion of the paper was as follows. The direction of growth changes. There is no way to inhibit growth, it is said. Using the device to push the jaw resulted in downward growth. Individuals who have used the chin cup are either experiencing an open bite, or have excessive wear on their TMJ, or have developed issues with TMD, leading to the conclusion that it is unsuitable for use. Therefore, the options left are either a facial mask or something like rampa. These have the disadvantage of being too difficult to wear. Pushing from the inside implies an orthopedic approach. So, from within, you push outward, or else there are upper jaw expansion devices like MAPI. There is also a method of using such a thing. Nevertheless, methods to induce the growth of the apical root or thus, growth and development proceed with this active growth like this. There are methods for induction, but there are no ways to reduce overgrowth. Ultimately, from that perspective, it can be considered that orthognathic surgery is necessary. However, some people wrongly criticize engaging in orthognathic studies. It is arrogance. One might say it stems from a lack of knowledge. That is arrogance. And you should not think that way. That constitutes passing on incorrect knowledge to the next generation, and as time passes, this will become the greatest obstacle on your intellectual journey. It is regrettable to see from the side. However, what's funny about them is this. Such dental occlusions in the mouth are often overlooked. I don't know well. It's also said that there's no need to know, and it's not even mentioned. Whether you move the jaw, stimulated growth, or inhibited growth, regardless of what has been done, we must maintain the jaw, just as the positions of the maxilla and mandible are determined. The factors such as mandibular holding and the position of the maxilla ultimately determine the positioning of the teeth. And if the teeth do not hold together in this interlocking structure, that treatment is not sustainable. I can assure you. Why? Because it is a mathematical model. This is not an empirical study. It is simply structured mathematically. That relates to geometry, similar to architecture, and civil engineering follows along the same lines. Next, apply force to the bone. This ultimately means that when stimulating mature bone to change its position, we are indeed applying force. So is it RP these days? The rapid palatal expansion is currently becoming quite popular. I expanded the maxilla. How can the mandible be open? The maxilla has completely collapsed. Arch discrepancy increases further. Of course, the mandible must also be expanded. However, it is thought that the mandible does not expand, and the discussion continues only on the maxillary device. Thus, it ends up becoming half-baked knowledge. It is regrettable and also uncomfortable to hear. Of course, they have also studied extensively. Though it seems to be a discussion about disseminating one's knowledge, a lack of understanding about dental occlusion leads to reduced stability. All claimed effects do indeed exist. The devices and treatments being discussed are all effective, however. Consider the concept that the position of the jaw, or how the position of the jaw is maintained by contact with the teeth, all square. I believe that we can achieve much better and more valuable treatment outcomes. Since this diagram might be complex, I have broken it down like this. This is what has happened. Mandibular holding is indicated in blue, while maxillary holding is marked in red. When actually taking a bite impression, it is impossible to separate the holding of the maxilla and mandible. Of course, there is also a method where the color of the articulating paper is made different for the upper and lower jaws. The maxilla can be marked in blue and the mandible in red, or they can be marked in different colors like this. However, they look identical to me. This is because we need to determine which one is the holding. To distinguish between them, I have indicated mandibular holding and maxillary holding in different colors like this. This is impossible with an occlusal paper. This would thus be considered a mandibular holding. If you look, there is 1 in the premolar and 3 in the molar, 3 each, making a total of how many? There are 14. Apologies. 6, 8, then 9, 10, 11, 12, 13, 14. That's 14 in total. The maxilla has 2 molars each, and then there is 1 more on each premolar. Thus we have come to understand holding. Thus, achieving maximum intercuspation in an all-square arrangement is, ultimately, the maxillary holding must interlock to become stable. It needs to stabilize. Therefore, ultimately, you will find that you must understand it in this way. This is a 2-dimensional representation, but you must perceive this image in 3 dimensions. Please take a moment to think this through a bit more on your own. You must conceptualize it in 3 dimensions in your mind. So, when these 14 holding structures interlock perfectly, how many are there in total on both sides? There are 28, which is the same as the number of teeth. One arch has 14 teeth, and if you include both the upper and lower, that makes 28 teeth. It's strange. It's probably a coincidence, but I mention it because it's easy to remember. So, what ultimately happens then? In cases of tripodism, there are 3, 3, 3, and 3 points within the mandibular first molars. This can be considered as 1 unit. So, if you subtract 2 from 15, you end up with about 13. In gnathology, it is said that there should be about 12 to 13 occlusal contacts in the mandibular molars. Most of you are just memorizing it because you don't know what the structure is like. Premolars are simple. 3 each, right? So if you understand the structure a bit, it's more visible. It's impossible to memorize all of this terminology and classifications. Upon examining the mouth, you can see the holding cusp forms an interlocking structure, causing it to imprint like this. When that image comes to mind, that should do it. Even after memorizing so much, we still don't reach a conclusion. I also memorized a lot since my school days. Looking back, there seems to be almost nothing left. I am currently studying languages, and just like when studying languages, memorization is involved. If you are not accustomed to speaking, you will not be able to express your thoughts coherently. It should come out naturally, as you want to say it. Reaching that stage, however, rote memorization does not seem to be a good method. Understanding, continuing to listen, and speaking in this way seems better. It is the same. To manage occlusion, you must frequently observe and understand patient cases on your own, repetitively engaging in imaginations to develop a habit. There is no other way to advance beyond this. I always do it that way as well. I will change the image in this way. If there is wear due to occlusal contact, as such, the combination is achieved, and either 3 or 2 holdings are marked on the mandibular molars. When we were in school, we learned that about 13 points should be marked, but as you can see in the image, there are only 3, and they also appear clumped together, looking like 2. It looks the same here. When it clumps together, it can also appear as one entity. It might be possible to have one in this direction. Unlike what we learned in school, if only about 2 areas are marked, you may start to wonder if you are doing something wrong. I did that. However, viewing the image in this manner, this type of contact point involves 3 surfaces coming together, and there is also a single surface on the buccal, lingual, followed by the mesial and distal surfaces overlapping. Then a holding structure is formed. In some respects, wear occurs. Of course, the holding power might be weaker than if there were no wear, but there is still a holding structure in place. When viewed this way, it's simple to understand. However, failing to grasp this concept can lead to headaches. I mentioned this because I hoped you would consider it further, so I would appreciate it if you could pay a bit more attention to it. When viewed as an occlusal adjustment surface, there are instances where the bite is eccentrically misaligned like this. Then, These holdings combine to appear as one or two entities. Do not be alarmed about how to handle this. Considering what we have imagined so far, you must reach a state where you can recognize it yourself based on that criterion. Epistemology suggests that what is seen is easy to learn. Without learning, without seeing, and without visibility, things are difficult to learn. Memorizing blindly and rote learning of terms do not facilitate visualization. If you can't imagine it, you won't be able to memorize it. Some also discuss gymnasts. If you can imagine movements such as jumping and rotating in your mind, you can also perform them in reality. If you can't visualize the movement in your mind, they say that practice alone won't suffice. Kim Yuna once mentioned in an interview that she has a good imagination. It was mentioned in a documentary as well. It was a documentary discussing the rivalry between Asada Mao and Kim Yuna. So it seems that Japanese gymnasts first use their imagination and then proceed with their training. It becomes visualized in your mind. Like us, by examining the oral cavity and visualizing it, and as AI programs learn, the accumulation of data ultimately allows us to understand at a glance. So this was it. Once the patterns are organized, I believe you will quickly understand which direction to take. So, ultimately, providing prosthodontic treatment comes down to this. If an implant is placed and not made to contact, the patient will quickly notice. So as I keep saying, it becomes comedy, not magic. The patient is clearly aware of what is not being touched. Some people insist everything is fine because they don't want to do it again. Because if an underbite occurs, it must be corrected, and to avoid that, we often insist on certain procedures with the patient. If it's clear that it isn't touching, will the patient acknowledge it? From the patient's perspective, it is inevitable to think that the director is treating them poorly due to ulterior motives. There are worse scenarios. Some directors will grind down the back teeth if a patient says they can't reach them. It seems you think that it will fit if you grind it down accordingly. Then the front will be raised higher. This needs to be ground down as well. This is also ground down. Ultimately, one side becomes an underbite and touches completely. If the opposite side is also ground down, both sides end up as underbites. As you keep grinding, the anterior teeth will make contact. Anterior repositioning is risky, so most often it is not pursued. When the jaw moves backward, it often results in premature anterior teeth. This can cause significant concern for the patient. The patient is unable to sleep and is in considerable distress. As the jaw recedes, the TMJ also becomes painful. Additionally, because the posture collapses, it also leads to shoulder and lower back pain. Therefore, there are those who use cupping therapy all over their body before coming here. I have seen patients who lost 5 kilograms in just 1 month due to severe difficulty. I have also seen many patients whose mental state became very unstable and who were unable to sleep. Therefore, occlusion should not be conducted in that way, and even if you perform an undercut, you must complete tripodism. We reduce the area. We must ensure that the patient does not notice. In fact, it will be slightly less chewable. However, we understand that the patient is affected. To avoid any sense of discomfort, it is necessary to create an underbite. If we completely undermine this, you are already aware, so I need not mention it. Very complex tasks are repeated endlessly. You should not do that. So, this issue is complex enough, but it seems that Oriental medicine doctors have been and are still significantly involved in treating TMD. When a splint is placed in the mouth and bitten down on, occlusion is disrupted. In traditional Korean clinics, the myobrace method is used, involving placing a silicone block in the mouth for biting. Thus, when biting hard becomes difficult, most TMJ conditions improve. In my experience as well, patients who suffered from joint pain saw rapid improvement with twin block therapy. By preventing chewing, it prevents strain on the joints. Therefore, I have often seen treatments that disrupt the occlusion. However, since a traditional Korean medicine doctor is not a dentist, he cannot adjust the occlusion. Instead, he employs a wise approach. This is because we first treat the TMJ and then send the patient to the dentist for orthodontic treatment. Since a traditional Korean medicine doctor cannot be responsible for a patient's occlusion treatment through to completion, when you refer a patient to a dental clinic for orthodontic treatment, Often the clinic does not understand the situation. Therefore, not understanding the Korean traditional medicine doctor ultimately leads to a repeated cycle of failing to improve relationships with patients. Therefore, myobrace is also widely used in China. So it seems that traditional Korean medicine practitioners have learned this and are using it as a purported cure-all. It seems that we are approaching TMJ treatment in that manner. If the occlusion is disrupted, the joint does not hurt. The joints may not be painful, but still, we need to align things like the maximum intercuspation of teeth in their new position, all square and so on. If a lever occurs, it will hurt again. Understanding the effects of lever action on joint compression will greatly benefit you in occlusal therapy. Since this is a lecture on implant occlusion, let's delve a little deeper into the topic of implant occlusion. In the case of molars, the center of rotation of the tooth is located towards the furcation. However, the implants are all engaged on the crestal side. Therefore, when overload occurs, the crestal bone is the first to resorb. Once it starts to deteriorate, it continues to descend, resulting in bone loss, progressing apically. This image shows an implant placed equicrestally. One of the reasons we place implants subcrestally is, as you can see, this lengthens the lever arm. When a consistent force is applied, the farther the lever arm, the more the force is dispersed, making it much more advantageous to place it subcrestally. So I keep saying that subcrestal is better than equicrestal. It seems that because this is a technically challenging skill, directors have difficulty accessing it immediately, which makes it feel more difficult. Here is the content. It would be good to give it some thought. This goes directly, you see. Thus, if we reduce the occlusal surface, there is less force applied, and if the occlusal surface increases, the lever action and lever arm are enhanced. It can be considered a slightly more disadvantageous situation. And you need to use a thick fixture. As the fixture becomes thinner, the contralevering becomes more severe. I believe this is one of the reasons why implants do not last long. You are implanting them too thinly. Most fixtures over 5 mm are not placed. However, 5 mm is too small a size for molars. This is referred to as the shortened dental arch, causing frequent significant tension. We continue to extract and implant both the first and second molars, constantly trying to reduce the surface area. I believe that method will not adequately resolve the issue. It would be beneficial to give some more thought to how this issue might be resolved. Although it is difficult to place a fixture that is exactly the same size as the natural tooth, I believe it is essential to implant one of a similar size to ensure proper restoration. On a slightly different note, I am opposed to the use of angled abutments. This is because when placing implants, they must invariably be positioned optimally. Using an angled abutment places a significant overload on the abutment connection. Therefore, the failure rate is high. Thus, when we look at long-lasting implants, we can see that those placed in good positions and in the right orientation tend to last longer, and implants that are placed deeper tend to last longer. I haven't done anything particularly special. Additionally, due to the severity of abutment connection issues, it is advisable to use abutment connections that do not allow micro-movements wherever possible. Next, we must use platform switching. Platform switching designs were of utmost importance to us. It's important. However, I believe the more important prime factor is how deeply to place the implant in a good position and orientation. Please consider this carefully and place the implant focusing on occlusion. Proper occlusal adjustment is essential for the longevity of implants. Additionally, it is important to use large-size fixtures. This is truly important, yet it is being greatly overlooked. Clinically, if one only pursues what is comfortable, even if the prosthesis doesn't fit precisely, this is acceptable. The patient is unaware. It's a concept of this nature. It seems that you often discuss this concept. Certainly the patient must be aware. All my patients are already aware of this. Therefore, by precisely fitting their prosthetics, they do not go to other dental clinics. I have been practicing in the same neighborhood for 31 years now, so I am still seeing patients who came to me 30 years ago. Of course, since 30 years have passed, some patients are unable to come due to their age. I once relocated my dental practice, but previous patients still come to see me. They keep coming unless there is a special problem. This is because older model implants require ongoing maintenance. I belong to the first generation of implant treatment in our country, having started my practice when Brainmark first entered Korea, progressing from Brainmark to Nobel Biocare. Having started using them from that time, there are quite a few very old implants. Zimmer too, and even earlier there was Paragon. In any case, I've placed quite a number of implants, and patients return if complications arise later. Ultimately, regardless of the type of implant, those that were placed in a good position with proper alignment and well-arranged occlusion have been well maintained. In the past, wide implants were not allowed. In the end, how we manage under occlusion seemed to be important. That's what I think. At that time, the concept was organized in such a way that when treating the mandible, we leave the maxillary teeth alone and proceed with the mandibular prosthesis. It seems that this results in buccalized occlusion. This is still valid today. For example, with posterior single crowns or bridges. If there is a lack of support and the implant is small in size, we eliminate the C contact. There are A, B, and C contacts. It is not possible to eliminate the holding contact. If the holding contact is eliminated, the teeth will move. Not only that, but the mandible will also move, so we cannot eliminate the holding contact. Since I do mandibular implant prostheses, saying that we cannot eliminate the holding contact means that the buccal holding cusp should engage with the opposing occlusal surface, and the lingual being non-holding means that if we reduce the occlusion on this side slightly, the patient may not even notice. There were also opposite cases. In one difficult case, for example, there was a premature contact on the lingual side. When there is premature contact on the non-holding side, the holding does not engage and the teeth will move. Then the patient complains of teeth being sensitive and feeling slippery. They say their jaw moves when they chew. That's what it means when we say holding is not possible. Since mandibular holding isn't possible, that's why we use that expression. So this was a case that required some thought. But in the past, it wasn't just implants being used. We also did a lot of bridges for second premolars and second molars, when the first molar was missing. In such situations, bridges seemed to be very useful. When second premolars and second molars were missing, buccalized occlusion could last over 20 to even 30 years. Patients don't really understand the therapeutic aspect. So, they thought the director's skills were good and even came to thank him. At that time, they used that, since the support wasn't good, I thought we should reduce something, so we reduced the table. However, the buccal table should not be reduced. It cannot be done because of the holding cusp. If you reduce the lingual, you ultimately eliminate the C contact. It disappears as a non-holding. That's how the simple logic began. But since that treatment lasts long, patients believe that I am skilled. However, rather than being inherently skilled, I have effectively used this concept. By reducing the occlusal surface and thereby lowering the occlusal load, it seems that ultimately this has resulted in implants that last longer. Maxillary implants are relatively straightforward. When placing maxillary implants, you can't reduce holding on the lingual side, so you reduce the buccal side. We call this lingualized occlusion and this buccalized occlusion, just that. There isn't any other reason. So it's done in such a way that only the lingual or only the buccal makes contact. Originally, lingualized occlusion, from what I understand, was developed in Eastern Europe or Russia as a method for dentures. Then it was brought to Japan, and there, the artificial teeth were set so that the buccal didn't make contact and only the lingual did, which didn't result in effective chewing. That's why there were also blade implants and things like screwdrivers attached. They created such significant devices to solve mechanical chewing issues. Originally, there was a lot of discussion about lingualized occlusion in dentures. It referred to what I just mentioned. By preventing contact on the buccal side and allowing only the lingual side to touch, it is easier to achieve fully balanced occlusion. It's very simple. That's why lingualized occlusion was used as an alternative occlusion technique for dentures. The technique for fully balanced occlusion is challenging, and there is a lack of confidence to achieve it. You can't abandon the patient, and if the denture doesn't achieve fully balanced occlusion, the teeth will dislodge. Continuously failing like that only causes discomfort to the patient. So, when considering what to do, avoiding contact on the buccal non-holding side simplifies the process. Thus, when doing upper and lower dentures, you can use this method. Allow only the holding areas to touch. By reducing the occlusal surface, it becomes straightforward. However, When doing either upper and lower dentures or implants, you can't secure the non-holding areas. By giving up on the non-holding areas, but maintaining the maxillary and mandibular holding areas and reducing the occlusal surface, longevity is achieved. Then you might wonder if the occlusal surface on this side can be reduced. It can, because without adjacent teeth, maintaining occlusion and overjet is not possible. Then issues arise with biting the tongue or cheek. About 20 years ago, when I went to a seminar in a different region, someone who attended the seminar approached me, saying that he has an elderly patient with a partial denture and complains of tongue pain. It wasn't that the tongue was being bitten. Having tried everything without success, he even referred the patient to a university hospital where they scraped the nerves. They scraped the mandibular nerve and the inferior alveolar nerve. He tried using neurogenic medications like tegretol for trigeminal nerve neuralgia, but nothing seemed to solve the issue. So I explained it to him. I mentioned that if the table is misaligned or there's a mismatch in the overbite, the tongue gets bitten. The cheeks can also get bitten. Then, when you ask him to bite down, the lateral border of the tongue aligns with the occlusal plane. But what if one side sags? What happens if one side of the occlusal plane sags? Ultimately, the tongue gets bitten, the cheek gets scraped, or the tongue gets scraped. There were many such patients, so I advised adjusting the occlusal plane. I received a call expressing immense gratitude. About 10 years ago, a colleague who left the partnership had a similar case, and I advised him to check the overjet and adjust the position of the occlusal surface. He also resolved the issue using that method. Therefore, reducing the occlusal table under occlusion seems simple in words, but in reality, it involves many complications. In this photo, as you can see, the appearance remains the same, but the overjet has increased. Similarly, the overjet in the maxilla has increased. Here too, on this side, the overjet has increased. If you maintain a similar overbite and increase the overjet slightly, you can prevent non-holding from touching. From the patient's perspective, since masticatory function is maintained and under occlusion is achieved, they feel it's satisfactory. I think I resolved a lot of cases using this method. It's still the same now. When creating a prosthetic with the opposing tooth descended, it becomes very complex. Various issues arise like this. So I usually persuade patients to either trim the teeth for prosthetics or consider implants like the lower teeth. From the patient's perspective, they prefer not to do it, so I explain the potential issues and persuade them. Then, the patient will feel discomfort while using the temporary. Then, they will agree to treat even the opposing teeth. It is important for me, as the doctor, not to force treatment but to persuade the patient. Since patients also experience what the problem is with the temporary, it becomes easier to resolve. I still follow this method. If you can't visualize it in your mind, you can't imagine it. In that case, you have no choice but to memorize. Buccalized occlusion, lingualized occlusion, how to reduce the table, you have no choice but to memorize. In fact, there is a problem with reducing the table as well. If the table of the adjacent teeth is high and the newly implanted table is narrow, the patient will quickly feel it. So I think there is also a problem with reducing the table. In any case, examine the situation from various perspectives. You should ensure proper occlusion so that this is a chart that seems to be created following nathology. In nathology, a similar chart is provided. It only shows the ideal. However, such ideal cases are not common. In this picture, the brown color at the front is the overbite. Class 2 results in a more pronounced overbite. This is a mild Class 2. Class 1 has an overbite of about 2 mm. When the overbite is normal, it aligns in a cusp to marginal ridge manner. Holding is. And when the bite deepens, the mandible is pushed slightly backwards like this. Therefore, it becomes cusp to marginal ridge. Cusp to fossa. Cusp to marginal ridge. Cusp to fossa in occlusion. This is what nathology considers to be normal occlusion. Because it was defined as food packing occurs known as plunge cusp when the cusp intrudes between the marginal ridges. Nathology made this judgment. But that doesn't make sense. Caucasians often have Class 2, so this condition naturally occurs. They also don't eat tough foods. Therefore, this condition develops. Cusp to marginal ridge occurs in Koreans and those with orthognathism. Now let's consider if the opposite side is made this way. What happens then if a prosthesis was placed here? If this side is cusp to fossa and the other side is cusp to marginal ridge, What happens is that the cusp on this side easily slides between the teeth. The same goes for the lower side. The mandible also has a structure that allows for smooth movement. On this side, the cusps interlock. Thus, after some time, the cusps interlock and wear down. In such cases, the cusps may become sharper. In any case, while there is no cusp interference on this side, the cusps interfere on that side, making it problematic. Therefore, I don't think it's ideal. Back then, I believed in and memorized the centric position tooth contact advocated by gnathology. Looking back, the position of the jaw changes in this way. It was such a simplistic issue, but I didn't consider the jaw's position and tried to memorize it blindly. Looking back, it seems that was the case, so I think that was slightly incorrect. Ultimately, the position of the holding cusp is crucial. I have explained how occlusion is achieved up to this point. In the case of Class 2, the maxillary holding cusp occludes entirely in a cusp-to-fossa relationship. This photo represents Class 2, and this diagram has been created as Class 3. When trying it as Class 3, a crossbite occurs, and ultimately, it seems to end up biting in this way. Lastly, we have created a very severe Class 2. When Class 2 becomes very severe, it changes to maximum intercuspation in centric relation. Ultimately, it varies according to the position of the jaw. The shape and size of the teeth are fundamental components. This is adjusted to fit the arch structure. The next thing to consider is the size ratio of the maxillary and mandibular arches. If it's small, it moves backward. Conversely, if the mandible is large, it moves forward in this manner. Therefore, when considering arch discrepancy, it's determined by the position of the jaw, and forced contact of the teeth occurs due to mandibular movement. Thus, there are these scenarios. I believe this leads to teeth contact in centric occlusion, maximum intercuspation. Therefore, there were a few such cases. When it comes to implants, most people only consider underbite, but that's not necessarily the case. This individual is a long-term patient who has been using implants successfully, and as you can see, is a bruxism patient. You can see that the centric is fully in contact and the eccentric is also in contact. I reduced the size a bit because there is a slight issue with the opposing tooth. The patient insists he will never get a crown, which is good news for me because he believes the implant will last a long time. However, because this side has a very heavy bite, I slightly reduced the occlusal surface. You can see the eccentric is also in contact. This was such a case. This case can be seen as one-to-one alignment with a cusp to fossa rather than a cusp to marginal ridge relationship. The teeth are all worn and the jaw has been pushed backward. The cusps have ground against each other, wearing the teeth down significantly. The lingual surfaces have also collided, causing considerable damage. This is quite a challenging patient. In such cases, if you perform an underbite, the patient notices immediately. As you can see, it is completely a group function. So to summarize, it seems that initially, the holding cusp was important. Holding cusp. Next is the centric concept. When the holding cusp interlocks to form the maximum intercuspation, it establishes the position of the jaw. The mandible is held. This has been and still is very important. Next, the arch structure. If the arch structure is not achieved in the teeth, malocclusion occurs. Then, issues arise even if just one tooth is missing. If it tilts towards the missing side, the occlusal contact changes entirely. This issue is a bit challenging. It's beneficial to form an arch structure, and establishing an all square seems to be the key point in centric occlusion adjustment. So, although there are various things to discuss, if you can visualize this in your mind, it should not pose a major issue. There are several complex problems. We generally create rules and keep memorizing them, so I've formulated principles in this manner as well. The first is the cusp to fossa relationship. It means aligning the holding cusps with each other. In simple terms, it means that the holding cusp aligns with the interlocking structure. The anterior teeth have a slanted structure, so holding interlocking is not possible. You just need to align the premolars and molars. It would be ideal if the occlusal plane is uniformly aligned. Next, I will explain the concepts of Spee, Wilson, and Mobius curve in the future. Following that, we have the pin and table concept. The holding cusp moves on the occlusal table. You can think of it this way. Eccentric movement is viewed as the process where the centric holding cusp moves on the occlusal surface. That's why it's done this way often. When the occlusal plane is not aligned, we adjust the occlusion by aligning the occlusal plane. Even if I am working on a mandibular crown, if the maxillary occlusal plane does not align, the maxillary should be adjusted. When taking an impression, you should use the concept of the occlusal plane, such as first adjusting the maxilla. This is because the pins move simultaneously. If the occlusal plane does not align, early contact points will appear. Once centric occlusal adjustment is completed, eccentric occlusion should be resolved by over 90%. With this concept in mind, you can simply adjust the high points. It's simple, just adjust the high points. There are no other reasons or principles, don't overthink it, just match cusp to fossa, and then properly align the occlusal curves. If the occlusal curves become uneven, you might achieve centric alignment, but in eccentric positions everything will come into contact. Therefore, if you ensure the uniformity of the occlusal plane by aligning the centric position, as far as I know, eccentric occlusal adjustment becomes almost unnecessary, resolving over 90%. With these considerations in mind, I think you just need to adjust the high spots. So anyway, once you align the cusp to the fossa, the patients will notice. It fits well, it chews well. You may not fully understand, but the patient does. You can only know by chewing for yourself. Even after leg or joint surgery, you can only know if the surgery was successful or not after the procedure. We know when we try chewing. I often have meals with patients. I always do my best, but I can't say with certainty that I do 100% well. Everyone has weaknesses, and there are limits to treatment. So, when patients suggest having a meal together or bring in acquaintances for treatment, it can be a bit nerve-wracking. In such cases, based on what I know, I provide treatments like aligning cusp to fossa or adjusting the occlusal plane. When I reduce the height, patients notice the difference. They mention feeling comfortable while eating together, and if things aren't right, they say they can't chew properly. When I hear such feedback, I either apologize and redo the treatment or explain why it might be misaligned. There is always a reason for the misalignment. Therefore, it's important to explain that additional treatment is necessary, and if there's malocclusion, orthodontic treatment is also required. When explaining the need for orthodontic treatment in a way that patients can reasonably understand, they agree to proceed. I hope you understand this well. With that, I'll conclude today's lecture on centric relation occlusion adjustment. I feel like my delivery might have been a bit scattered, but I believe I've covered almost everything I know. With my book coming out, I hope to discuss occlusal adjustment in more detail at a future opportunity. Next week, I'll be presenting on the centric occlusal adjustment. Thank you for your attention. That will be all for today.